In the last lesson, we have learned that evidence comes from studies that are more likely to hit the target, that is, the underlying truth. In other words, there is variable strength of evidence, depending on how close the clinical research is likely to be to the center. It is therefore not we have evidence or we do not have evidence. Evidence comes in shades of gray. We call this hierarchy of evidence. Hierarchy of evidence for treatment is as follows. The strongest evidence regarding a certain patient's treatment comes from a so-called N-of-1 trial. It is difficult to think of an N-of-1 trial in psychiatry. But for example, if a patient with migraine to whom you prescribed a new medication comes back to you saying, "Doctor, I understand your explanation how effective the new drug is, but I feel that the old one works better for me," then you can run an N-of-1 RCT in which that patient takes the new drug and the old drug in a random order for each new bout of migraine. If it turns out that the old drug is indeed more effective than the new one, then there is no stronger evidence that this drug is better for that patient. When we cannot have such individualized evidence, RCTs and their meta-analyses constitute the strongest evidence. When such randomized evidence is not available, then observational studies, such as cohort studies or case control studies, can provide some evidence. When such systematic studies are not available, we still have weak evidence based on case series, case reports, pathophysiological studies, or even expert opinions. Hierarchy of evidence means there is no clinical question for which we don't have any evidence. In the least, we may have case reports or expert opinions. However, in any given instance, we would like to follow the strongest evidence. For example, acute fulminant hepatitis B was a lethal disease and had killed 9 out of 9 recent cases. When Gok administered immunotherapy to the 10th patient in hepatic coma, he survived. Out of the ensuing 7 similar cases, 4 survived. Gok originally thought that the effectiveness of immunotherapy had been established. However, Gok reasoned that he could not rule out confounding by more intensive supportive care or by earlier diagnosis in more recent cases. He concluded that he needed a controlled trial rather than to add another unproven therapy for fulminant hepatitis. In a double-blind RCT in which Gok himself participated that compared immunotherapy and albumin placebo, the mortality was 72% in the former and 68% in the latter. Charles Huggins discovered hormonal influences on prostate cancers in the 1940s. This was the first cancer to be shown to be responsive to hormones, and Huggins was awarded the 1966 Nobel Prize for Physiology or Medicine. At about the same time, between 1960 and 1975, VA Cooperative Urological Research Group conducted a series of RCTs for prostate cancers. When they compared placebo, estrogen, orchiectomy plus placebo, and orchiectomy plus estrogen, there was no difference in overall survival among the 4 treatment groups. A Nobel Prize cannot beat an RCT for matters clinical. Let's come to a more psychiatric example. PTSD has received much public interest after the Great Hanshin earthquake in 1995 in Japan. Psychological debriefing was widely advocated for routine use following major traumatic events during the 1980s and 1990s. In an RCT of psychological debriefing, the intervention group had a significantly worse outcome at 3 years. Those who initially had PTSD symptoms remained symptomatic if they had received psychological debriefing, but recovered if they did not. More than 30 observational studies, including cohort ones, had shown that hormonal replacement therapy decreased coronary heart disease, so that the guideline issued in 1992 by the American College of Physicians stated, women who have coronary heart disease or who are at increased risk for coronary heart disease are likely to benefit from hormone therapy. The primary prevention trial for women without history of CHD showed that hormone therapy increased CHD up to 6 years. The secondary prevention trial for postmenopausal women with history of CHD showed that the recurrence rates were no different between HRT or placebo for 4 years or even 7 years. Observational studies can go wrong. So, evidence has a hierarchy. Evidence comes in shades of gray. Let us follow the strongest evidence available, especially with regard to treatments. For in treatments, we add something to the status quo, and that something had better do more good than harm.